Many psychiatric conditions can be treated in outpatient settings, but sometimes they need additional treatments. Being hospitalized for psychiatric issues tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is off tonight on a well-deserved vacation. I'm Dr. Deb Johnston with the Avera Medical Group in Brookings. According to the Center for Disease Control, or the CDC, 63.3 million people visited their physician's office, were hospital outpatients, or entered emergency departments with mental disorders as their primary diagnosis. We'll take a look at some of the disorders, and particularly the ones that may cause hospitalizations tonight. First, let's take a look at this week's Prairie Doc Quiz question. True or false? A psychiatric or mental health disorder is a behavioral or mental pattern that results in dysfunction in life and may occur in a single episode, relapsing episodes, or become persistent. True or false? We'll have the answer at the end of the show. Joining us tonight is Dr. Matthew Stanley with Avera Medical Group University Psychiatry Associates in Sioux Falls. It's great to have you here, Matt. Tell us a little about your background.
You bet. Well, so I'm a psychiatrist. I do work for Avera. I'm the medical director at our facility there and vice president for the behavioral health service line. One of the things that Avera is trying to do as part of its mission and part of our being a good community partner is expand our access to psychiatry. As you mentioned with the CDC statistic, it's a terribly common area of need. I've lived in Sioux Falls for over the last 20 years, completed my residency with the University of South Dakota there at Avera, and actually I'm a SDSU graduate, so it was coming home.
So you didn't get lost on the way to the building today.
Well, the campus has changed a lot since I was here, but I was able to find my way.
All right. So what drew you to psychiatry in medical school?
That's a great question. So in undergrad, since we're talking about SDSU, I found I guess that subject matter one of the most interesting. Even though I ended up with a bio major and chem minor, I also got a minor in psychology just out of interest. And then actually went to medical school with the intent to be a primary care or a pediatrician because I love kids, love family medicine. I was kind of inspired by my own hometown doc, so I wanted to follow his footsteps. But once again, when I rotated through psychiatry, I just found that every story was unique, that the interactions were fascinating, and also felt like, the medicine's improvement in the area of psychiatry was just beginning to surface. It was kind of the last great frontier to explore the brain, to develop better treatments. And so that along with just the patient interaction really drew me in.
There's been such a huge revolution in psychiatry, especially I think over the course of the last 20 to 30 years, just in how open people are to the idea of having depression or anxiety and the treatment options we have available for them. It really is a very exciting time to be practicing medicine from that regard. And psychiatry is such a huge part of primary care practice too, that there's just a lot of overlap there. I remember when I started practicing, people would come in and one of the biggest complaints that I would get would be fatigue. And we would go through everything and we would do all the labs and we would ask all the questions, and at the end of it I'd look at them and I'd say, do you think you might be depressed? And yeah, maybe that's it. And now people will come in and they'll tell me, I think I'm depressed. And it's just a huge change in the way people understand mental health, and that's such a good thing.
I completely agree. We've come so far. If you think when I began my residency, Prozac had just come out. Yeah.
Oh, and wasn't that revolutionary?
It was. It truly was.
Oh my
gosh,
gosh,
if you think of where we've come from there, and I will be the first to say medicine isn't the entire answer, but the options we have and the benefits they have done for many, many people are phenomenal.
And Prozac is still a great drug.
It is.
It's still got a really good role.
And one of the things that I'm sure you understand and our patients need to understand is, you know, although we have developed many antidepressants with many different methods of action since that time, and you go back before Prozac where it was the tricyclics
And
were
the
the
mouse.
first, MAO inhibitors. No drug that we've developed since has been proven to be more effective than what we began with. What we have improved on is things like fewer side effects and safety. But unfortunately, we still have not conquered the, I guess for lack of a better term, the need for almost a trial and error effort on the part of treating our patients for their depression. So it's frustrating if you're not doing well and the first medication doesn't work. We often have to wait 4 weeks for a full trial.
Or longer.
Or longer.
And titrate up those doses and put up with those side effects. And it's a hard thing. It's so frustrating because people have felt so bad for so long that when they finally get around to being willing to accept some help, it's so hard to wait.
So there's another area we hope to continue to make improvement, and I know that we're going to have a little discussion about genetics here shortly, and that is certainly a very promising area of study. You know, there's also technology like fMRIs and things that can show amazing things at the cellular level. One of the key things I think for our patients, and one of the things you touched on, we have come a long way in, I guess, the general public acknowledging that psychiatric illnesses are of a medical nature.
And that they're legitimate and that it's not just a personal failing. And
I think we still have a long way to go, though.
Yes, we do.
But when you begin to look at things like MRI studies and genetic studies, they do validate the medical model of psychiatric illness. And the Surgeon General, in his address and in his paper here just a few months ago, really validated it. He was addressing more of the substance abuse, but it was very clear that he was saying all our evidence shows that addictions are a medical illness, as is behavioral health. So when you hear that from the Surgeon General, and it was historic because he had never, the Surgeon General's office had never addressed the behavioral health component before. So for him to say that, I think continues to legitimize that these are medical illnesses. It's appropriate to seek help. It is not a weakness of character. It's not a failure of you or your environment. Seek help. So hopefully that message continues.
And my hope is that, particularly with that message about addiction, is that we'll see more encouragement, more openness, more availability of treatment, and treatment, inpatient treatment, outpatient treatment, structured treatment options for addiction, because I think that's something that's been really lacking in a lot of ways. I mean, it's that sense that, oh, well, this is just, you just need to cut that out, has really handicapped recovery for many people who suffer with that disease. So.
And along that line, there are now, just like we talked about Prozac coming out in my residency, so over 20 years ago, there's now beginning to be medications targeted at recovery from addictions.
Right. And I think, you know, a little more inpatient treatment options and residential treatment options for people that are battling addictions. And so one question is, you know, with mental health in general, I obviously see a lot of people with psychiatric issues, but the issues that I see are on a whole different plane, a whole different level than the issues that you see. So it's pretty obvious to me, oh boy, this person needs more expertise than I can offer them. How do you make the decision? What guides you to decide, you know what, this person needs more than I can give them in an office visit once a week or once a month, or boy, we really need to be adjusting medications more quickly. How do you make that decision? What makes you decide that this person could stand a hospitalization, or it might be a benefit to that person?
So sometimes that decision is difficult, although the criteria we would use are relatively clear. So one of the most common reasons that we would hospitalize a patient is we are at extreme concern that they may try to take their life. Suicidality, risk of harm to self, is still our #1 reason for hospitalization. More rarely applied is the risk of harm to someone else. And this is usually through a delusional disorder, some form of psychosis where, a paranoid delusion makes someone believe that someone is out to hurt them, so they're going to strike first or, retaliate, that kind of thing. So those, harm to self, harm to others, pretty clear criteria. Although I can tell you it sounds clear as we sit here and talk about it, it's not always clear in person or face-to-face with a patient. You mentioned a couple other things, though. There are those patients that just are unable to function in their environment. They have become so ill. They may not be voicing suicidal ideation, but they're incapable of feeding themselves, clothing themselves, taking medication, so they're not going to continue to improve in an outpatient setting. So those folks, just failure to have an ability to thrive or even to maybe survive outpatient, not through a direct threat to themselves, but just for lack of self-care. And then the final one is what you also mentioned, just I am not having success in treating this patient. We need a higher intensity of environment.
And wouldn't it be nice if it was always that clear to make that decision for the individual in front of you? So yeah, wonderful, wonderful discussion. And fortunately, we have Avera Behavioral Health to help us when we need that. So the Avera Behavioral Health Center in Sioux Falls is a great asset to eastern South Dakota and beyond.
We're also one of the low-cost providers when we compare ourselves with others across the country. There are many facilities that have come to take a look at our facility. After they've done that, they comment about the facility, what a wonderful place it is, but they often comment on our staff. What a wonderful staff you have and how focused they are on patient care and giving quality services to those we serve. The Avera Behavioral Health Center has been here for a little over 10 years now. 24 hours a day we have folks here who are master's level counselors, social workers, and psychiatric nurses. They assist people who are referring individuals to our center, and they also assist individuals who walk in. Those walk-ins can occur at any time of the day or night. What we do is help assess their level of need, what type of service they need, and then help them get to that program. We have over 9,000 calls a year for services, and we do also over 6,000 face-to-face assessments per year. So if someone comes to our facility and needs an assessment, we would greet them at the front reception area, and then we would come in here for an intake interview. It's a psychosocial history with a special emphasis upon psychiatric history. That information is then compiled and provided to our on-call psychiatrist, who then would make a decision about whether the person needs to be admitted or if we could refer to outpatient care. We have 5 inpatient units, ranging from child and adolescent, special units for each age group, and then 3 adult units. We also have a geriatric program which is located on the Avera Prince of Peace campus in southeastern Sioux Falls. Altogether in this building we have 110 inpatient beds across these 5 inpatient units. In the public areas of the Avera Behavioral Health Center, we have about 32 pieces of commissioned artwork done by regional artists. This building has a theme verse that comes out of Psalms that was chosen by our sisters, by the Benedictine and Presentation sisters, who are our sponsors. That verse out of Psalms 139 talks about, I will rise on the wings of the dawn, and wherever I go, you'll be there with me. So the artist translated that theme, Wings of the Dawn, into birds, doves, kites, and those kinds of themes within the commissioned artwork. This is one of a series of 4 paintings by Mary Goth, and what she's done is she's put hope in the primary languages that are spoken here at the Avera Behavioral Health Center. This is hope in Lakota, and here we have hope in Spanish with the symbolism of the wings of the dawn with the kite and the butterfly symbolism. Hope in English. And lastly, hope in Arabic. This is the group room, classroom on our child unit. It is a classroom for kids ages 4 through about 12 that get served on our program. And so every day the kids are in here doing crafts, they're doing academic work. So a lot of things occur in this room, including teaching social skills. We have things that we remind kids of. They earn points by doing good things to each other and for themselves while they're here. This is our On the Wings of the Dawn stage that staff designed and constructed here on the children's unit. Theme of hope with our butterflies. So a variety of speakers come in and present. We've had folks do a variety of good things for our kids, including puppeteering and musical instrument shows. This is another one of our pieces of original commissioned artwork. This one's done by James Starkey. It's entitled Hope. James Starkey, as a Native American artist, wanted to make certain that he knew the orientation of our building so that when he did the sunrise, it's on the right there, that's oriented to the east, which it is. And it was very important that we have this painting in a location by the area where we do serve a number of Native American adolescents, but also that we honor and recognize James' request for the placement of this painting to be done correctly and according to his wishes. There's hope for individuals who have psychiatric disorders, and we want them to seek treatment and wherever that might be, and we want them to feel better, because they will feel better after being in treatment.
I just love seeing that building. It's such a beautiful therapeutic environment. It's just really exciting to see that. Let's talk a little bit about the range of treatment options that we have for people. I mean, there's so many things that we can do. Counseling and medications, and one of the things that I think people are often really afraid of and probably shouldn't be is ECT.
It's a great topic. I'm glad you brought it up. So I am one of our providers of ECT at the Avera facility we just viewed. You're absolutely right. It is an underused therapy because it has had, I think, so many poor portrayals probably in movies.
People think about One Flew Over the Cuckoo's Nest, and they think it's this horrible thing. But ECT stands for electroconvulsive therapy, and so I mean,
commonly known as shock therapy.
And we all of us here in the Midwest have that experience of having, gone out to the electric fence as a kid, and So tell us what it's like being in the room when a person has ECT therapy.
So it's obviously very different than what we've seen in the movies. So when we perform ECT, we've talked to the patient, explained the procedure, full consent is given, but they're lying on a gurney, they have an IV in. We use a couple of drugs, methotrexate, a very brief acting anesthetic, and we use acetylcholine to block the muscle movement. So the patient's asleep and their muscles won't react. When we do ECT, we are inducing a seizure, but the patient lies there. We monitor their cardiac rhythm, we monitor blood pressure, pulse, I monitor brain waves on a separate machine.
Their brain has the seizure, but their body doesn't.
Correct.
Yep.
And since the 1930s, when electroconvulsive therapy was first, tried, discovered, however you want to put it, it has always been effective. What has changed over the years is the comfort and safety for the patient. So I would tell you that currently with ECT, in terms of the correct answer on a board question, there is no absolute contraindication to ECT, meaning you can give it to anyone. And surprisingly, or maybe counterintuitively, some of the people who respond the best to ECT are older patients, usually more frail, usually have more co-occurring medical difficulties.
More difficulty, more interactions for all those drugs that I may not want to use.
Absolutely.
Yep.
And the interesting thing, we talked about the course of a trial of medication. ECT usually takes 6 to 9 treatments, and we do a treatment every Monday, Wednesday, Friday. So we're talking about 2 or 3 weeks to full recovery, not just beginning to show signs.
And do these people need to stay on a medication then? Or can the ECT, now we don't need a medicine?
We typically will keep people on a medication because the reality, when we talk about depression, which is the primary indication for using ECT, people, I think, have a misconception to a degree of the natural course of depression. So the vast majority of people will have a depressive episode maybe once in their life, but they see it more as a reaction to certain stressors. When we're treating people with ECT, or people that I will treat, they're usually the people who've had a more severe form of depression that's far more recurrent. Statistically, if you've had one episode of depression in your life, you have a 50% chance to have a second.
Oh,
if you've
50, I thought it was 30.
Yeah, a little
well,
higher.
There you go, I learned something tonight.
So if you've had a second and a third, your odds are 75, 80, 90. It just keeps escalating. Yeah. And typically when I will see people that are receiving ECT, it's one of two reasons. They've had a very severe course and nothing else seemed to work as well. Or, as you kind of alluded to, other medications just didn't work, they didn't tolerate them. So they're really they've come to us as a last resort, unfortunately, because ECT probably deserves consideration earlier in treatment. But because those people have such a recurrent course, it's really about managing the illness. So we suggest that they both stay on a medication, maybe fewer medicines at a lower dose, but we'll also often prescribe maintenance ECT. So have them come back maybe once every 4 weeks or 5 weeks, depending on what we can get it out to. But for those people, depression is more like a chronic disease, more like you would treat diabetes. Correct.
High blood pressure.
And when you treat diabetes, it's all of the things that we would talk about with depression. It isn't just the right dose of insulin. The corollary would be the right dose of antidepressant. It's also, you need to watch your diet. You need to exercise. You need to watch out about infections. There's a whole course of instruction. And it's about how you live your life, and it's about learning for you as an individual how to manage your illness. And that's really the discussion we need to have more so with our patients in depression. I think most people still kind of assume if I find the right medication, that's all I have to do and I'll be well. And we know that there's more to it than that.
Yes, yes. I usually tell my patients, you know, the ones who do the best are the ones who go to therapy, that learn those new ways of responding to the stresses that they deal with all the time, and relearn the things that got their brain into the first in the first place.
We don't realize the ruts we get into in thinking.
Yes.
And two of the most effective through research, the most evidence-based approaches from a therapy standpoint are cognitive behavioral therapy and dialectical behavioral therapy. And they both really work at addressing just what you described. Incorrect, I'll call them ruts of thinking that we fall into and probably don't even recognize anymore. We just immediately jump to certain assumptions about ourselves, about our environment, about the future. And those negative messages, that negative reel.
Self-talk.
Exactly. It continues almost in the background to the point we don't recognize it anymore, but we certainly aren't attempting to redirect it in a more positive manner.
So explain a little bit about the difference between those two therapies.
So I would say that, and I won't pretend to be an expert on either one. Cognitive behavioral therapy would do exactly what we were talking about. You try to identify and address the incorrect assumptions, the incorrect mental framework that you've been operating under.
I'm stupid, this is never going to work, yeah. I can't do this, I might as well not even try.
Correct. And dialectical behavioral therapy, DBT, does some of that, but it's a little more about identifying skill sets, identifying what I can do when I get upset, identifying, first of all, where is my emotional level. DBT is probably addressed more so to some of the personality disorders, like borderline personality, who have a high risk of self-harm, a high risk of suicidal thoughts. And one of the things that often is problematic is just the ability to identify where they're at in terms of an emotional response.
I see that so much with people. I think particularly maybe in the Midwest, where we're kind of taught to be stoic and tough, and people just don't acknowledge how they're feeling about things.
And it doesn't matter what your illness is. If you don't have insight into your illness, it's exceedingly hard to make progress.
Yep.
So I think, and again, you're a practitioner who does very well with people with mental health issues, but one of the things that is incumbent on us as we treat people is to try to get to that point of understanding where they really do understand the nature of their illness and the idea that it's going to take time, it's going to take effort, and we may not get it right on the first time. It's so easy to get discouraged. The other thing I would say is, I would say lay people don't understand how much depression, the true illness of depression, can change your way of thinking.
Oh, yeah.
Your perception can become totally off. So when people say, you know, he wasn't,
lies.
yeah, absolutely.
Depression lies.
And when people say he wasn't acting like himself, that's absolutely correct. I've seen people that have committed suicide, and the family will say, he would have never done that. Well, he wouldn't have in his right frame of mind. I can tell you how powerful depression is. I can give you an example. Severe depression will often result, not often, but can result in hallucinations, auditory hallucinations. That is the extreme end of changing your perception and skewing it and confusing it. But
you actually hear that voice. I mean, we all have an inner monologue where we talk to ourselves and our brain tells us things, but those people actually hear that. They physically hear a voice telling them, you're stupid, you don't belong here, you don't deserve anything
messages,
good.
Which just drives them further down.
Yes.
So I use that as an example of this illness is so powerful, it can create a voice in your head that you will believe is real, that is telling you negative messages. That's how powerful this illness can get at its extreme end. But like all illnesses, this occurs on a spectrum. The point being, perception changes. And you can't always, when you're depressed, you cannot always trust your perception.
Let's talk a little bit about bipolar, because I think there's a lot of overlap, there's a lot of confusion about what's bipolar, what's depression, what's bipolar depression. So how do we tell the difference between depression, bipolar depression, and effectively what's the difference?
Yeah, so the first episode of depression, you really can't tell. And most commonly, people with bipolar disorder will have their first event be a depressive episode. It's really hard to tell that a patient's bipolar until they've had some kind of elevated mood. So bipolar, the diagnosis is those who suffer both depression, and the depression can be as severe as any kind of single depressive episode, but they also have elevated periods, whether it's hypomanic or manic. They will have periods where energy is greater, mood is higher.
Crabby, irritable.
They can be crabby and irritable, they need less sleep, they start engaging in more activities, they're more easily frustrated. It's
distractible, bad judgment.
So the difference being, in terms of a treatment, as you asked, what is the difference? Evidence is pretty clear that when we treat the bipolar depression with antidepressant alone, we will create more cycling in that individual. The hard part is
go from being down and sad to being irritable, up, bad judgment.
And they will cycle more, so then they'll drop down, they'll go up. And the difficulty is, however, that most people with bipolar disorder spend the majority of their time in a depressed mood. We're trying to seek the middle ground.
Which is hard because, it's kind of fun to be up here.
It is. Well, that's the other thing. So people with bipolar disorder, they really crave that mania, so they're not always compliant with their medications. So really the difference is, if you treat with an unopposed antidepressant, you're probably going to trigger more episodes, and you're going to trigger potentially more hypomania or mania. So we use mood stabilizers in those folks. Lithium is the classic oldest drug that we have used. Not always the most frequently used anymore. We have newer drugs, Depakote, Topamax, Lamictal, several medications.
Seizure medicines.
Right, they are mostly seizure medicines, which leads us to believe there's something about membrane stabilization that is probably the most effective part, or what is actually occurring at the
molecular level in the brain, cellular level.
There you go.
Yeah.
So but it can be very hard to diagnose. The other thing is all mood swings are not bipolar disorder. Some people have, like we talked about borderline personality disorder, some people who have very reactive characters, very reactive personality aspects, feel they're bipolar. It's a very different type of mood swing. You know, an experienced clinician can usually make a difference, but it's one of the risks of self-diagnosis. You can start chasing a lot of medications that won't really help the problem, and in fact will have side effects and issues.
Yeah,
Yeah,
potentially can make the problem worse.
Right.
Yeah, such an interesting field. So, one of the really exciting things, I think, is the medical genetics, and I think we talked about this just a little bit earlier, and I think that that holds a lot of promise for us as clinicians as we try to help those more intractable patients who have a lot of side effects and have failed a lot of medications. So there have been big advances in genetics that translate into significant steps in how drugs are chosen and in the dosing.
Pharmacogenomics is the buzzword, and it's a big word in the media right now. And if you break apart pharmacogenomics, you think about it as pharmacy and genetics, and pharmacy being the medications that we take for all sorts of different conditions every single day, whether it's blood pressure, high cholesterol, whether it's diabetes, depression medications, and so forth. We're mapping those and trying to best understand how they're metabolized through the liver and other different pathways. So what we're doing is we're taking a simple blood sample, and so your provider will order this clinical laboratory test for you. You have a blood sample drawn. If it's difficult to obtain a blood sample, we do have other steps that we could take, such as a cheek swab, and then we will look at your particular DNA from your blood, and from that the laboratory will give us the results. We come up with a specialized recommendation list, and it will literally have a color report that has columns for green, yellow, and red with use as directed, the cautionary group, which might have more risk of drug interactions or more adverse effects, and then the red group, which we're significantly more cautious with, that maybe the doctor needs to increase the monitoring. Maybe it's best to avoid that medication altogether and find one that would be a little bit easier for you to use and better tolerated. So we do the testing right in Sioux Falls at the Avera Institute for Human Genetics. So if you are tested anywhere in the Avera health system by blood or by cheek swab, that sample comes by courier to our lab, just like if you're having a blood count done, if you're having labs done before you go to surgery. Those labs get processed, brought out to us at the Avera Institute for Human Genetics, and we do all the clinical work right there too with our clinical specialized team. The insurances that are maybe a little more innovative and willing to talk on a one-by-one basis and do the prior authorization for this, we're willing to pay in those unique situations. It was well over $1,000 previously. We've taken that price point down by continuing to maximize efficiencies in our laboratory as well as with our clinical team, so that it's at a much more cost affordable price for the general healthcare consumer and patients. It is very much, the patients a lot of times are their own advocates and saying, hey, I've tried now these 3-4 medications. I'm still not feeling that great of benefit, but I heard about this story and I'd really wonder what your opinion is, and do you think this would be a good test? And so they can discuss it with their physician. They can say, hey, here's what's happened in the past. Let's try this test, which will help narrow down our choices and best kind of target the next best medication. And so we really, at Avera, we try to do our absolute best to give people all the options, all the support with that holistic approach of mind, body, and soul. So let's not make it so we have this great technology available, but you can't afford to have it. So we're really trying to make it affordable, accessible for all of our patients, whether you're being seen at primary care or with psychiatry here at behavioral health. I would definitely recommend talking to your physician, whether primary care or psychiatrist at Avera. But if you want to just call our laboratory and talk to our clinical team, you can call us at 605-322-3050. And we'd be more than happy to help you and discuss with your physician. If you're unsure how to talk about the test, feel free, just reach out to us.
So I'm actually really excited about this test being more accessible. I mean, I think the current price is $150 for that panel, and I know I found it helpful on occasion in my practice, and I'm sure that you've had occasion to use it in your practice. So when do you first recall having started to use that?
You know, it's been a few years now. So one of the things that I think is fascinating about genetics is we're still just touching the surface. You know, when the U.S. first mapped the human genome, I think everybody expected, you know, within the next year, all these great things would come of this. We'd understand everything because we'd have the genetic map to guide us. So we are still realizing the potential of what genetic testing can do for us. But one of the great things it does for me as a psychiatrist is that several of our drugs are metabolized through pathways in the liver. And for instance, one of those really common pathways is cytochrome P450-2D6. That will metabolize drugs like Paxil, very common drugs, Prozac. However, 7% of Caucasians don't contain or don't create
They don't do it very
an effective 2D6 level of enzymes. So in other words, those drugs are not going to get metabolized. They're going to build up in your system. You're going to feel rotten. They're not going to be effective because you can't tolerate them. So smart clinicians maybe caught on to that years ago when they were treating, but now we can test. We can identify people who aren't going to tolerate some drugs. And I think we can eliminate some of that frustration in that long period of trial and error. Better than that is that once you have been had your enzymes and your genetic idiosyncrasies identified, that doesn't change for the rest of your life. So unlike normal labs we go in for, Krista identified white blood cell count, which we'll often get prior to tell us if we have an infection going on or something. Well, that's going to change virtually every day, but certainly with our medical condition, genetics is static. Once you know what my liver enzyme, how it operates, it will be that way forever. So, you know, for the next 50 years, as you prescribe medications to me, you know, well, Matt Stanley doesn't have an active 2D6 enzyme gene, so we got to avoid those drugs.
Yep.
So it helps us not just today, but will give that patient greater information as they go forward in their life and receive health care.
I think it's really important, though, when we look at that, to recognize that although this is really useful and really exciting information, this is information about how your body processes this drug. It's not necessarily going to tell me, oh, gee, look, you don't process this drug well, you don't process this drug well, you do process this drug well, so this is the drug for you. Well, that's great that you process it well, but it may not be, maybe we've got 4 drugs that you process well, I may still have to go through 4 drugs to find a drug that works well for you.
Absolutely right. One of the still most common frustrations with patients, they think if we get the genetic testing, we'll be able to just target specifically, here's what you need, here's how much of it you need, and this will treat your illness. We're not there yet. As I said, you know, I think we all believed in this expectation. We map the human genome and we'll have the answers to everything. We're not there yet. We're gaining ground.
Yes.
But for instance, to be able to diagnose a specific illness, we talked about the difference between unipolar and bipolar depression. It would be lovely to have a gene test that could tell me before I ever started to treat you, this is the type of disorder you have, so we're going to need to use a mood stabilizer and et cetera. We're not there yet. And
even asking my family history, I may have 2 siblings with bipolar and 1 sibling with unipolar. Do I have regular old depression? Do I have bipolar? You know, it's...
We still don't know. I mean, it changes the odds a little bit. You probably have one or the other, unfortunately, because these do run in families.
So strongly genetic. And let's talk about that a little bit, because that's something that comes up a lot, the whole nature versus nurture issue. So where do we stand with understanding where mental illness, where depression, where anxiety, where bipolar, where schizophrenia? We haven't even talked about schizophrenia, and that's such an important issue.
Right, and so what we do know, as you said, clearly there are genetics at work here, and we see this run in families. whether it is an illness like schizophrenia or depression, which is more common, or let's go back to the discussion we had earlier about addictions.
Addiction, yes.
All those things clearly have a genetic component. However, we're not ready to say that you are damned from your moment of birth to have a disorder. So the current outlook on almost all disorders, whether it's behavioral health or maybe colon cancer, doesn't matter.
Diabetes,
Right.
hypertension, heart disease.
What we know is you have a predisposition based on your genetics to have a certain disorder. And then at some point, an environmental stressor or something will probably trigger that genetic change, which will give you the illness. So that's not to say that it's the environment's fault. So it's not how you were parented. It's not how you were schooled. But there is environment, whether it's heat, light, events, acting on your genetic makeup. So genes get turned on and off. Genes get modified, activated by the environment. That's why you'll see even identical twins, one can have a disorder and the other won't. Their genetic makeup is essentially the same, but one unfortunately had an illness triggered and one didn't. So we have relative statistics of what it's like if you have both parents with depression, one parent with depression. We can give you relative odds, but we don't yet, we wouldn't yet say that those genetics are you're destined to have a specific outcome. What's more interesting about that idea that genes can be turned on or off by events in the environment is if we can identify people earlier before the illness takes a chance, do we have the opportunity to intervene?
Make them more resilient,
right,
protect them from
exactly.
those diseases.
Because a lot of the genes that predispose us to illness also have a component in them that may make us more resilient, may actually be beneficial if we can trigger it the right way. So again, it's that promise of genetics, which is fascinating, but we haven't yet achieved what we will over the next few decades.
It's very exciting time. And epigenetics, that's another potentially exciting field. So
Right.
Stay tuned, everybody. There's a lot of exciting things that we can do. So let's talk a minute about epigenetics. So let's explain that for our listeners, our viewers.
Well, epigenetics is a little bit what we're talking about. It's kind of the overlap of what occurs to turn genes on or what modifies genes, and so it's a field unto itself. So there is genetics, the pure science, which Krista was kind of describing. We're able to identify what your genetic basis is, but then it's
what genes are activated, what genes.
It's the on-off switches.
And there's some concepts that are really kind of just starting to be investigated about the idea that there can be genetic changes, genetic stress-related changes that can be passed on through generations too. So that's another very interesting idea.
I think unfortunately it's genetics, like everything that we have discovered about the human body, certainly the human mind, is not quite as simple as we first
Thought it would
believed
be.
when we started to open the box. It's like I said, I think everyone believed, after we mapped the human genome, which was a phenomenal accomplishment.
Yes.
Well, we're only a year or two from understanding all these illnesses. Well, the reality is we're a decade or two down the road, and we're still trying to figure out what it all means and how to put it together in a way that really changes population health.
Yes, and can be utilized for the individual too. I mean, that's another whole level of understanding. So
Right.
It's really very exciting. So let's talk a little about some of the more disabling conditions, the more disabling chronic conditions, like schizophrenia. I mean, that's can be a very devastating disease.
It is, and although we can treat some of the worst symptoms of that disorder, we still cannot cure it, make it go away. And unfortunately, you know, it tends to hit in 18 to 22-year-old individuals about the time they're going away to college or beginning their first career. So just at the time when life seems to hold the most potential for you, you're struck by an illness that can be devastating. In schizophrenia, the symptoms that are most common in that, what we would call the positive symptoms of schizophrenia, are the hallucinations. Typically, auditory hallucinations are the most common. So the idea,
kind of like those voices we were talking about a
Exactly.
little bit
Yeah.
earlier for those severely depressed people.
right. Less common are visual hallucinations. You'll see something that truly isn't there. And then there's more the delusional components, the belief that you know, people are out to get you, somebody's always following you, your room is bugged, the government's after you. So there's delusional components or hallucinatory components. Those are the most common symptoms. But the other things that occur are you tend to isolate more, you take less care of yourself, you tend to start talking less, you actually tend to kind of reduce the amount of thinking you do. So it comes with a whole constellation of symptoms.
And what percentage of your hospitalized patients would you say are your schizophrenic patients, or how often do these patients end up in the hospital?
Well, one of the sad things about the illness is it does follow a chronic course. So although we can treat it, you know, people tend to at best stay static in their lifestyle. But there is kind of an economic and even an intellectual decline that occurs over time in a lot of these patients. So they become probably less functional in society, and so tend to have fewer resources over time. Fewer resources usually correlates to more frequent hospitalization. I would say at any given time it's you know, 10 to 15% of our inpatient hospital population.
It's such a hard disease, and I think when we think about homelessness and mental illness, a lot of those individuals have something like schizophrenia or uncontrolled bipolar, or the more severe and less treatable mental illnesses. So
I'm always appalled when I visit larger cities because I recognize that in so many of those homeless people.
Yep, it's really hard. What would you say your average length of stay is at Avera?
Relatively short. So it's in the 5 to 7 day for most patients. Remember that most of our patients come in due to a risk of harm to themselves. So someone who comes in with a severe episode of schizophrenia may be a bit longer than that. But oftentimes, if we can kind of reduce the crisis for a patient with suicidal ideation, create a nice environment, a safer environment for them to come back to, about 5 days, 5 to 7.
And I know the state hospital is in Yankton, so how often do patients end up there for a longer stay, would you say?
Again, not a large percentage. State hospital does a great job. It's such a needed resource for us.
Boy, yes.
But you know, maybe 10, 15, 20%. Those are typically the people that appear that they're going to need a longer recovery time.
And need a little more marshaling of resources, and
Oftentimes.
that's often, I think, you know, from my perspective as a primary care person, one of the biggest challenges is that these mental illnesses, particularly the severe mental illnesses, can be so isolating and can be so exhausting, and people's resources just get depleted. So trying to rebuild that support network and, you know, where are you going to stay, and how are you going to take care of yourself, and what options are you going to have is just a huge issue.
We mentioned insight earlier, and a lot of times when you become psychotic, you've lost insight. You're not really aware of yourself and your illness.
And what you need. It's a devastating thing. So I am very, very glad that we have you and your colleagues here in South Dakota to help us. It's a huge
Deb.
benefit. So thank you so much. And now for the answer to tonight's Prairie Doc Quiz question, which you'll remember, it's a true or false question. A psychiatric or mental health disorder is a behavioral or mental pattern that results in dysfunction in life and may occur in a single episode, relapsing episodes, or become persistent. True or false? And the answer is, if you've been paying attention, true. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
Last week I learned of research showing empathy, caring about the other guy, is very important for an individual's success in life. Evidently, it pays to be a caring person. It's interesting to note that these researchers thought compassion for another results in likability, which then in turn brings success. In contrast, a group of psychiatric diagnoses called personality disorders are all about the lack of empathy. Of course, the whole story is extremely complicated, but to generalize about people with these diagnoses, one can say these individuals have an impaired ability to think about and be considerate of the other guy. It's believed that these people have incorrect self-image issues and a dysfunctional response to stress. The cause for such a troubled life is likely a combination of an inherited personality type and because of inconsistent or too little discipline, as well as too little or too much attention as a child. To make matters worse, those with a personality disorder do not seem to learn from their mistakes or to learn that their behavior is errant, possibly because their self-image is so wrong and entirely different from how others see them. When they do seek medical care, they usually want help for secondary problems of depression, anxiety, or alcohol, drug abuse, and not because they realize how bad their behavior has been. This weekend, I had the joy of spending time watching my cousin's grandchildren, and it struck me that a self-centered way of thinking with anger and belittling of others is normal for children, that being considerate of others is something we hopefully grow into as we mature, and that the most mature and self-actuated adult even feels the joy of another's success. A friend who helps drug addicts and alcohol men recover pointed out to me one time that the most important lesson for these impaired men is to help them realize it's not just about you. In this sometimes cruel and competitive world, it's nice to see research support for the golden truth that it pays to be a caring person.
A big thank you to our guest, Dr. Matt Stanley, for coming to the studio tonight. It's always good to have you. It was really good to have a conversation with you tonight.
Thanks, Deb. Likewise. Enjoyed being here.
Thank you. And a reminder to all you at home, vaccinations are not just for kids. Check with your medical care provider to see if there are any vaccinations you should be getting. Flu shots. And that does it for all of us here on Call with the Prairie Doc. Till next time, stay healthy out there, people.
Can't get enough of the Prairie Doc? Then visit our webpage and other online programming. You'll find extended interviews with guests and more information on important medical subjects. Visit prairiedoc.org or follow us on Facebook. The best way to stay healthy out there.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with the ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
South Dakota State Medical Association,
the Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Aberdeen Asthma and Allergy,
Black Hills Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Regional Health,
Swiftdell Communications,